evening to everyone. I am Astha Bansal, here a resident at SN Chennai, and I would like to welcome all of you to our 26th edition of these Powwow Meets. This month's focus is on pediatric ophthalm. Our moderator is Dr. Akshay Bhadkare sir, and over to you, sir.
Thanks, Asta. We have three moderators, very experienced moderators today. All three are very good in complex strabismus cases, and I'm sure we'll all get to learn a lot from their collective experience. I would like to first introduce Dr. Ram Prakash. He currently works at Kanchi Kamakote Child Trust Hospital and has his own setup, Radha Eye Care. He also freelances in Chennai and has almost 2 decades worth of experience. And I have been very fortunate to hear a lot of his talks, and he simplifies strabismus whenever he teaches it. He really simplifies it, and it's very enjoyable to listen to all his talks. The second moderator is Dr. Akhila Ramkumar. She's my colleague at Shankar Netralaya. She's also the Deputy Director of Academics. Very good teacher, excellent surgeon, and again, really good in complex strabismus. Our third moderator is my good friend, Dr. Varda Gokhale. She works at, she's the director at Madhav Netralaya in Nagpur. And as I said, I'm sure from all three of them, we'll collectively learn a lot about exotropic DRS and complex strabismus alike. So that's it. And over to you, Dr. Rishi.
Thank you, Dr. Akshay. And I think I'll start with the presentation. Actually, it's always a pleasure to be associated with the academic activities of Shankar Netralaya alumnus. So this is, I'm going to present on exotropic Duane syndrome. And I'm going to present a couple of cases and how they were managed. Essentially, it is for Y-split recession, I mean, both the cases. So I'll be going into the depth of that procedure and how we got the results with that, and then after that we can discuss a few points regarding exotropic DRS as well as the other different types of Duane syndrome. Okay, so I'll start with the first case. A 9-year-old male who presented to me with right face turn since early childhood. Parents had also noticed an abnormal eye movement in the left eye. Usually when this type of history is given, we usually think in terms of Duane syndrome. Now, this 9-year-old child is quite cooperative for or the orthoptic evaluation and ocular motility part, but sometimes the child is really young. So at least you can suspect about Duane syndrome if such a history is given by the mother, especially. As regards this child, the visual acuity was normal. Rest of the ophthalmic examination was normal. There was no refractive error as such. So he had a very prominent right-sided face turn. So I mean, even on we actually needed a lot of effort to correct his head posture when we were doing the orthoptic evaluation. So I'll just show you the ocular motility. You can see some amount of left exotropia which is there in the left eye. And there was a limited abduction in the left eye as well as adduction, and a bit about globe retraction. And if you follow the globe retraction grading here, it fell into the category of grade 1 with some amount of upshoot which he had in the left eye. So we also did the right eye ocular motility was normal. He was not very cooperative for side gazes, so we did the orthoptic evaluation in the primary and up gaze and down gaze, which showed around 10 prism diopters of exotropia in the left eye, slightly more in the up gaze, but not down gaze it was the same. So based upon the clinical features, we diagnosed him as a case of exotropic Duane syndrome type 3 with the right face turn with grade 1 globe retraction and mild upshoot. Usually for Duane syndrome, whenever it's exotropic Duane, the face turn will be on the opposite side. Like in this case, it was on the right side when the problematic eye was the left eye. Whereas in esotropik Duane, usually you get the face turn on the same side. So I tried to find out before offering any treatment, what are the concerns of the parents. Obviously, the main concern was the abnormal head posture in this case. And also the parents had noticed about globe retraction and upshoot, which were also a concern. Ocular motility limitation, they had not noticed. It was something which I pointed out to them. So even now, I think we had just a question half an hour before on this group about, I mean, what are the primary concerns or what should be the main indication for doing Duane syndrome surgery. I still don't touch a Duane syndrome if there is no abnormal head posture, especially unilateral cases. So in this case, there was a phase turn. So we planned a left eye lateral rectus recession of around 10 millimeters with a Y split of around 16 millimeters under general anesthesia. A word about how this recession and Y split works. Actually, it reduces the muscle power, it reduces the effective lever arm, which is R, and thereby reducing the torsional force, which is torque. Thanks to my son, actually, I'm taking his physics right now, so I can explain this in a bit if sometime. Yeah. So basically, if you consider torque is basically a product of the perpendicular force acting on the rotational arm. So it is given, the unit is around newtons meters. So Newton stands for force and meter is the rotational arm. So what happens is it I mean, the product of these two forces along with the sine of the angle through which the rotational force takes place is given as torque. So when it comes to, I mean, if we try to apply it on the eyeball, what we do in Y split is we recess the muscle. Now, if you want to reduce the torque, you have to reduce either the R or the F or the theta or all of them. So R can be reduced by doing the recession, which we very well are aware of. Force, actually, if we want to reduce the force, now usually in Duane syndrome, there is co-contracture of the lateral rectus on attempted adduction. So ideally, to reduce the force of rotational force of the generated by the lateral rectus, we have to decenervate the muscle, which we cannot do. So what we do is we try to cancel these forces by doing a Y split. So when we do a Y split, actually we are, I mean, force is a vector. So these two forces are acting in opposite direction. And also, instead of this 90-degree angle, the sine 90 is 1, if we reduce it to 45 or 30 degrees by doing a Y split, the sine of that angle is also reduced. So the effective force is definitely less than what it was previously. So that is how the Y split works. So in this case, we did a Y split and we could get sufficiently good result in terms of the abnormal head posture as well as the amount of, I'll just show the video of this patient. This is a post-operative video. And there was the exotropia had reduced. Ocular motility was, I mean, there was a limitation. Some amount of globe retraction is still present, but upshoot has definitely gone down. So the parents were satisfied, especially because the abnormal head posture and the upshoot had reduced. So this is what we could achieve. This is at 1 month post-op. So coming to a second case, actually, this is a bit different than what it was just I shared. A 29-year-old male who had outward deviation of the eyes, and he had noticed some weird eye movements since early childhood. There was, because of financial constraint, he could not undergo any treatment anywhere. But now, for marriage purpose, he wanted to get his squint corrected. He had a mild left face turn, as you can see from the photo. Rest of his ophthalmic examination, including his visual acuity, was normal, no refractive error present. I thought initially it's just a case of a simple exotropia, do a recess resect or a bilateral recession, and you can get away with this. However, as you can see, this is his ocular movement, and this is on attempted adduction. He has got a downshoot and globe retraction in the left eye. There was I mean, you can see on attempted adduction in the right eye also there is a globe retraction, and he can I mean, he's trying to actually adduct and abduct lateral movement, which he's unable to do it. Only the up gaze and down gaze is possible. So he had we also tried to do an orthoptic evaluation, which was possible only in primary gaze, and you can see he has got an exotropia of around 30 prism diopters in the left eye with right hyper, which increased on down gaze, but in up gaze it remained the same. So based upon the clinical features, he was diagnosed as a case of a bilateral exotropic Duane syndrome type 3 with downshoot. Bilateral, it was more in the left eye. Now the patient's primary concern was exotropia, like he had come with the primary complaint of that, and also about the downshoot, which he mentioned as a weird eye movement. Globe retraction is something which we observed, and also ocular motility limitation. He had concern with this also, but we explained that whatever treatment we offer, we may not be able to correct the limitation, ocular movement limitation completely. So before, I mean, this was my first instance of tackling a bilateral exotropic doings. So I went through literature. Usually, this is the article I follow, Dr. Pradeep Sharma et al. And IGO. And towards the end of this article, actually, they have mentioned about bilateral exotropic doings, which is quite rare and usually can be tackled with lateral rectus recession or a Y-split, just like doing a unilateral surgery. So my thought process was pretty clear, or it was seconded by this article. This article also mentions a flow chart. If I think many of you have already studied this, that if there is some amount of lateral rectus movement present, then Y-split will definitely work. But if there is no LR movement, then periosteal fixation, and in addition to that, for residual EZO which might be generated, we can do a VRT or a superior rectus transposition. I thought of doing the lateral rectus recession with Y-split. So we aimed for doing around more than 12 millimeters of lateral rectus recession, supramaximal, with 20 millimeter Y-split or 10 millimeter from the midline between the split tendons. So sorry for the quality of the video. Actually, this was not properly focused, but this is the right eye. For normally, if we are going to do a recession for routine case, I am easily able to reach the lateral rectus, but in this case, the FDT was really, really tight. So I had to apply this Mersilk suture close to the limbus and move the globe. And then I did, I hooked the lateral rectus and removed the intermuscular septum. I had to use two double-armed Vicryl suture and decide the place how to split them. And this is the superior part of the muscle is already under suture. Now I'm doing the suturing for the inferior part of the tendon. After doing this, you have to take care that you create a hole in the muscle so that the muscle can be split without damaging the sutures which you have already passed. Then use a iris repositor which can be passed posteriorly in order to separate the tendon. Basically, you can't go much behind, so I had to disinsert the muscle. After disinsertion, you will notice that usually the close to the insertion, the tendon has to be cut using a scissor. The tendon can be split either by using the scissor or simply you can be torn off the way we do for a paper. I was able to recess go around 12 millimeters posterior to the original insertion site, so recession could be achieved. But 10 millimeter split was a bit difficult, so I could get around 9 millimeter on either side. This is the lower part of the split tendon that I am passing the suture through. At the end of the surgery, I just measured all the using a caliper how much I was able to achieve. So I was able to achieve around 12 millimeters of recession with 18 millimeter between the split tendons. The same procedure was repeated for the other eye, and this is 1 week post-op. So you can see that the exotropia has got corrected significantly. I mean, the patient is quite satisfied with that. And obviously, the movement was limited, but the downshoot which was present prior to surgery in the left eye had, is not present anymore. Some amount of horizontal movement had come, but even the downshoot in the right eye also is not there anymore. So this is something which we could achieve by doing a Y-split. You can see the pre and the post-operative photographs. So I went through literature to find out if about any reporting of similar case. Dr. Suma Ganesh and their group from Shroff Charity Hospital have reported a similar case of a 12-year-old boy who had a bilateral exotropic doens, but they handled it by doing a hangback recession instead of a Y-split, which I did in my case. So I went through literature to find out about case series of exotropic doens. One is from the LV Prasad group and one is from Iran, where they have done retrospective study, and both the groups have suggested that just a recession or Y-split recession can be effective surgery for many of these cases. However, there is one recent article which has mentioned that if downshoot or globe retraction is the primary concern, then medial rectus recession in addition to Y-split recession of the lateral rectus can be added. But if the primary concern is globe retraction and not the face turn. So with this, I would like to conclude by saying that for exotropic Duane syndrome, you have to understand the patient's concerns, and accordingly, you have to set certain realistic expectation and individualize every case. Though there are certain general rules which we follow for cases of Duane syndrome, every case has to be individualized based upon what you are actually seeing and what are the concerns of the patients or their parents. Usually, the culprit muscle is believed to be the lateral rectus for all cases of Duane syndrome. So when you are doing a recession for lateral rectus, you have to do it liberally. But medial rectus, you have to be really a miser. You have to do it around 2 to 3 millimeter on minimal recession. So I would like to thank for your attention, and we can discuss this further. Thank you.
Thanks, Dr. Rishi. Two lovely cases, and I think we all know how tricky Duane retraction syndrome is, because decision making becomes very important there. So I would like to start with Dr. Ram Prakash. Sir, when Dr. Rishi mentioned in the conclusion that setting realistic expectations are very important. So, when you see patients in your private practice or in child trust, what are some of the 3 or 4 points that you tell them are your goals for surgery? Because they would probably focus on the eye movement only, but for us as as strabismologists, we have a different set of goals. So, what do you discuss with them?
It definitely involves a lot of chat time, not over single visit, sometimes over multiple visits. And especially in this case, the patient is already having a lateral rectus, abduction limitation. And when you're going to do a lateral rectus recession, there is a chance of worsening of the abduction limitation. So besides the other goals that Dr. Rishi mentioned, setting realistic goals, we need to counsel about this also, that the patient's abduction might worsen after the surgery and they must be prepared for that. Besides whatever has been mentioned, tell them that it's only for correction of the abnormal air posture. That also, even a small residual is acceptable, and correction of globe retraction, everything, it's not possible to give a 100% guarantee. It needs multiple visits sometimes, not over one visit, because the parents are very anxious and they want to get the surgery done at any cost. So we need to take certain, little extra time and counsel them on these points. So in this patient, I will be especially cautious about counseling them about the worsening of abduction limitation.
Okay, right. Yes. To Dr. I would like to ask Dr. Akhila now. Ma'am, you have so much experience handling complex strabismus cases. Dr. Rishi showed a beautiful video, and in that he made Y split look so simple. But we know Y split is actually, when it comes to the space in the orbit while operating, there's a lot of limitation for space and all that. So for what are some of the surgical tips you would like to give us when it comes to handling a DRS case, especially doing the Y split?
In lateral rectus is usually fibrotic and it might be really thin. So you should be cautious not to pull it a little too much because muscle also snap. And you should have, splitting, I think it should be okay because I have never had any difficulty as such in splitting or 16 millimeter splitting is like actually doable. It's not that difficult. Only thing that fibrotic muscle, you need to be a little cautious when you're taking the stay sutures. And one more thing I would like to add, in cases of this upshoot and downshoot, you should be able to differentiate a mechanical upshoot or a downshoot from a neurogenic cause for the vertical deviation. So, because if you're wanting to do a Y split, only if it's a mechanical cause which is causing the split, Y split works. But if it's a neurological cause which is causing the vertical deviation, which can be picked up in the primary gaze position, the patient has a primary gaze vertical in advance, it is very, very unlikely to be a mechanical cause for the upshoot and the downshoot, in which case you can handle the vertical muscle rather than doing a Y split. So that is something which I would like to add, because in this case, I don't know if in the second case, if you told that there was a little bit of a hypertrophy on the primary gaze, in which case usually advanced mechanical this thing, what happens is on attempted adduction, there will be a slow drifting of the eye upwards, which is more in favor of a neurogenic. I don't know. This is something which I would specifically look for when I'm planning a Y split.
I have one question. Regarding the method of splitting the muscle. Once you have created, the space in between, how do you separate those tendons? Do you use Just tear it apart.
No, I use first to make a buttonhole in that midpoint,
Yeah.
and then I split it with a hook,
Okay. Okay.
small hook.
I use the
Split
iris
it as
repositor.
much posteriorly as possible, and then I measure it, and then I place it apart.
Yeah, I think the small hook, the teaser hook, and the iris repositor both are actually
Yeah,
used.
even iris
Both are good.
repositor once in a while, but small hook works.
Yeah. Varda,
Uh,
when you do this Y splits, any special instruments or anything that you would like to keep ready, which you feel you would need uh, in these cases? Because for me, I always keep thinking for a Y split, it looks easy, it's easy to read and understand, but while doing it, it's actually it is a bit of a struggle, isn't it?
Fine. So very nicely done cases, Dr. Rishi. I must congratulate you. Very good post-operative results. What precautions I'll take while doing LR split is first take a large limbal incision. We need good exposure. So I usually take suture after splitting the muscle. So like after make a small neck and then took two bites of 60 Vigryl, two different sutures, and then I cut it. And splitting was easier using either iris hook, repositor, or a small Cincy or teaser hook can uh, make we can nicely keep the fibers apart. We need good exposure, so I use Barbie a lot if I need to go 10 millimeters from the center above and below. So that helped me. But 12 millimeters of recession you did in one case from original insertion and going back after that 10 millimeters up and down will be a little difficult unless you
Yeah.
have a very
I
huge.
could not achieve that. I was able to get 8 to 9 millimeter only.
I have done it for like 6 millimeters of LR recession and then split. So it was pretty easier. Not surgically, not that difficult to do it. So both
Right.
it was good. What I would like to add in bilateral duons, whatever angle we are measuring is always a secondary angle. So it is always something which is more than normal angle. So we need to be prepared for that. So if we do too much of recession of LR, we might get overcorrections.
Yeah. So I was
Actually,
that
Raman,
would.
sometimes it's better to stage it, like in what Dr. Varsha mentioned. The angle that we measure might be more, so it's preferable to do one eye first, and then see how the response is, and then maybe take up the other eye. And the other thing is, whenever the extra instruments that we need to have, usually I don't use a marker pen. For these cases,
Yeah.
it's preferable to have a marker pen so that you can mark the distance, and probably a dismiss retractor. That also helps to retract the conjunctiva a little more. And nowadays, whenever there is a tight muscle, before starting the dissection, I take a non-observable suture through the bulk of the muscle, little behind. That's to make sure that just to make sure that the muscle doesn't get cut off and we lose the muscle. So though it's less likely to happen with lateral lectures, for any muscle that is tight, I take a temporary suture through the muscle bulk so that the muscle doesn't get lost if it gets cut.
So now we saw two cases of exotropic duans with upshoots. Supposing we have, sometimes we see bilateral exotropic duans where the upshoot might be very, very minimal, but its angle is large. Say we have 40 prisms of exotropia, very minimal upshoot. Then what should be our approach there? Varda, I'll start with you this time. So bilateral exotropic duans, very minimal upshoot, uh, large angle. How do you manage this case then?
Probably if there is very less upshoot and co-contracture, I will go with bilateral simple lateral rectus recession. So I may not do the Y split unless I get extremely tight lateral rectus on table. But preferably bilateral LR recession will be my first choice of surgery in both eyes, like bilateral LR recession. May not touch
Yeah.
the MR.
I think the challenge also would be that there are no like surgical nomograms for this. So we need to do an
Yeah.
FTT and then plan how much to do. Yeah. Yeah. Ma'am, we are, ma'am, some we again, now we discussed about bilateral cases. Sometimes we have unilateral duans, say left eye exotropic duans, but large angle again. So we keep discussing about asymmetrical LR recession. What's your thought about this asymmetrical LR recession? How do you plan surgery in these cases?
If it's lesser than 20 XT unilateral, then single muscle lateral rectus recession works. But if it is more than that, then you need to keep bilateral, lateral rectus recession in mind. And you do a larger recession on the normal eye compared to the affected eye. Or if you feel that you want to add a transposition to effectively add to the amount of exotropia correction that you want, then you need to plan a vertical transposition also. Keep that options in mind when you plan your surgery. But bilateral surgery is what I would take as a first step. Then stage transposition, I always do it as a second stage.
Right. Any of you have experience using a grooved hook in these cases, like for a tight muscle? I personally haven't, but four of you here, have you used a grooved hook or anything for these tight muscles?
No, I haven't used.
No, I just take precaution that I take a bite little posterior than normal, little bit, not too much posterior. And then when I do this, I lift the muscle insertion a little so that we don't take accidental bite to the screen.
Yeah, right.
I have one question. I mean, coming to, is the as a fellow, we were made to, we are taught that the basic indication for surgery for Duane's is the abnormal head posture. That was the primary concern, or that is the primary indication. But has that still remained, or now many of the surgeons are they doing it for other indications, even if there is no abnormal head posture? What is your experience?
It's always a combination of factors, no? Like just based on for one indication, I don't think I would rush and do a surgery. So I need to have at least 2 or 3 indications. So abnormal head posture along with upshoot, abnormal head posture along with globe retraction. So it's always not just one factor for me. It should be 2 or more.
I think the order would be one AHP. Is it there? Is it significant or no? It's a very small abnormal head posture. Probably nothing is needed, or you could probably give a small prism and manage it without touching the eye. Primary position deviation, is it something that's causing a cosmetic blemish or no? If it's a small primary position deviation, no AHP, nothing to be done. Diplopia, yes or no? Upshoot, is that upshoot cosmetically hindering the patient or causing a abnormal head posture? Like in your case, I think that the first case, that boy was adopting a face turn because he was having an upshoot in the left eye. So I
Yes.
think, as Dr. Ramprakash said, it's a combination of factors always. Orthotropic duans, no HP. I think it's best not to touch at all.
I still remember a 15-year-old girl. Of course, the indication was abnormal head posture. After surgery, she started crying because she could herself fix the what we call toad on her ear. Before that, she had to depend on someone else. So that was always an eye opener, which we don't think of these indications.
Yeah.
And because I think it's a general audience that's there here, or is it purely pediatric?
No, it's a mix of pediatric and general.
So just a lighter note on the type 3 duans. It's the second most common. The first most common is type 1 duans, and type 3 is the second most common, and type 3 will be the least common. And usually it has a predilection for the left eye, or again predilection for females for some reasons. Whereas type 3 duans and type 2, they show lesser of this predilection. They might involve, still the left eye is more common, but right eye is more often involved than in type 1. And when we are exposing the muscles, we need to look for additional slips or insertions, and check FDT at every point before disinsertion and after disinsertion. That must be kept in mind. And the most common type of amblyopia is it's due to the associated refractive error, not due to the strabismus per se. It can happen, but it's more often anisometropic amblyopia and very often hypermetropic.
Yeah.
In fact, hypermetropic amblyopia might be associated with some amount of accommodative esotropia also. So always give glasses if it's significant. Reassess, especially in patients with esotropic duans.
And also look for systemic anomalies in case if you see a child with Duane's or something, if you're the first person who's coming across, just look for other systemic associations in Duane's because it might be a syndromic Duane's. That also need to be kept in mind.
Do the long-term results of a Y-split recession remain the same, or do they, I mean, go into exo again? I haven't followed up for very long actually, these two patients. So.
Ma'am,
Unfortunately,
you
I
can
don't have a
go
long-term follower because whatever I see, they get lost somewhere. So I'm not sure about the long-term follower. At least 2 years they do well.
Yeah, the person got married. I mean, the second case, he is married now, so he hasn't come back after that.
So I would like to ask others regarding role of transpositions. What is your take on transpositions for Duane's?
Am I audible?
Yeah, Varda, finally you are audible.
Have you tried this transposition or vertical split transpositions or modified Nishidas for Duane's?
So I've not tried it in Duans, but it depends on how is the co-contracture. If there is co-contracture, I will never think about vertical rectus transposition. So you have to really look for contraction. It may worsen if we do vertical rectus transposition. So do it whenever there is no offshoot, no co-contracture. You can do VRT. Um, I've done it only one case, only vertical rectus, superior rectus, but it worked well. Plain exotropic Duan.
Okay.
But
I've
I
done it
agree
for
with
esotropic
Dr.
duans, not for exotropic. I mean,
Okay.
yeah, nasally.
superior rectus transposition along the lateral rectus to improve the abduction.
Even
But
for
that is
exotropic duans,
Just
even
to
for
stop it.
exotropic duans, transversion has been suggested.
Yeah.
When you are doing a supramaximal recession of the lateral rectus or doing a periosteal fixation, where you are taking the lateral muscle off the globe, that cases uh, rectus transposition can be done. My experience also is limited, like Dr. Varda mentioned. So we need to be very careful. Though Hunter and his group, David Hunter, they claim that significant co-contraction is not a contraindication. But the consensus is it's a relative contraindication. We need to be very careful because it can worsen the co-contraction and palpebral fissure narrowing. So we need to be very careful when the globe retraction is significant.
I just wanted to discuss any experience on a contralateral eye lateral rectus recession with a posterior fixation in exotropic Duans. Like that will not be my first choice, but there are cases saying you can do supramaximal lateral rectus recession with a Fadden-like thing in the good eye, like fixing eye.
I don't
No,
have any
I
experience.
no experience. But I
And
think
it's
there are
difficult to convince the
literature
parents also. Theoretically, yes, it is possible, but it's very difficult to convince the parents, no? Because these
Yes.
parents have already been advised not to do anything by many old-time ophthalmologists and others. So to counsel them for surgery itself in the first place is difficult, and to counsel them on the surgery for a good eye is going to be even more difficult. And what would be the indication for the same? Is it to match the reduction deficit on the other eye?
Yes,
Okay.
to match the duction deficit.
think principle of fixation duress they call it, right?
Duress. Okay.
Uh, even I
but
haven't
very
done.
difficult to convince the, as Dr. Ram Prakash has said,
Yeah.
to operate on the normal.
Ma'am, Dr. Akira, you were
And the
talking
other
about.
thing is when you're doing the lateral rectus recession on the other side, on the affected side, there's a chance of improving the palpebral fissure. Widening also can happen. That we lose if you are going to do it on the normal line. No? In fact, if there is an asymmetry, it's going to be even worse when you do it on the normal.
Yeah. You're talking of modified Nishidas in exotropic DRS, right, ma'am?
Yeah.
So what has your experience been with? Like, what cases would you either try to do these, or if you have done, what has your experience been with it? Because it's actually a good surgery.
One article on Kushner, I think, if I remember, with Dr. Karthikeyan on modified Nishidas along with the lateral rectus recession. He has actually done a lateral rectus periosteal fixation along with a modified Nishida to correct the exotropic demands in the absence of co-contraction or upshoot or a downshoot. So I have done one case in which it has worked well. So I'm yet to see the patient on a long-term follow-up because GA I have seen 6 weeks post-op. But then long-term, I really don't know the outcome. But it cosmetically, it gave me good results.
So you
And what
did
type of anesthesia do you use in general? Is
If
it
it's an
local
adult,
or general?
if it's an adult Nishida, I do it under local anesthesia also.
Okay. Because sometimes
Because
I face the issues with
unilateral,
local anesthesia in adults. The muscles are really tight, and when we hook them and pull, no, the patient get really they get a discomfort, and sometimes we have to stop and then start again little later. And there's also a more chance of ocular cardiac reflux.
touch wood. I have not had it.
I wanted
If
to
it's
ask about the
under local
Nishidas.
anesthesia, OCR actually doesn't happen.
I mean, I'm sorry.
It's
You
less.
attach the superior and inferior rectus along the lateral rectus. The Nishidas which you did for your case, along with the
No, you
periosteum.
split that is 1/3 of the superior and the inferior rectus. You take pre-placement sutures and then you fix it in the superior nasal and the inferior nasal quadrant, midpoint between the two, superior and the medial and the inferior and the medial. It does work because that corrects around 15 to 20% of diplopia. So it adds to your recession. So if there is something, if you want to plan it in one eye in an adult and you don't want to touch the other eye, where most of the patients are sensitive about when you offer surgery on the other eye for a little larger recession, I mean 20, more than 20, you have around 30, and you want to just make do with one eye, then you can combine a lateral rectus recession with a modified Nishida, which gives you an addition of 15 to 20. So it has worked in
Added
one case,
advantage.
which was an ideal case, which I tried, but it has worked. But I don't know on
The
the
advantage will be that it would also avoid the risk of anti-segment ischemia because they are not disinserting the muscle.
because you're not touching too many.
Okay, yeah. I think Dr. Rishi, you were saying something, right? You were asking something.
The same. How did she do the Nishidas? That's what.
Okay, okay.
Just explain.
Right, right. Yeah,
we
so
think we do not prefer a lot of resection in most of the DRS cases. We try to avoid resections. So that is one take.
The last paper which I just shared about doing a medial rectus recession also, along with a Y-split recession of the lateral rectus. Any experience anybody has with this, especially for
A
the
very limited experience. Yes, I have done both, like recession of the same in the same eye of both medial rectus and lateral rectus. That is for significant globe retraction. The problem is you'll have to adjust the dosage for the underlying squint corresponding. So you'll have to do more of, suppose the patient is esotropic. If you're going to do
In addition to
medial rectus recession, you should increase. But the problem is if you increase, there is a risk of consecutive exotropia, especially when the patient looks into other side. So in these situations, when you're doing both recession on the same eye, we might have to add the contralateral medial rectus recession for esotropic device.
So, Dr. Ramprakash, just on the same point, exotropic devance, you said for a large face turn, you would do recession in both eyes, correct? So, how would you adjust the dosage in terms of what would you do more, what would you do less, so that you don't end up getting a reasonable primary position correction also? Because theoretically, I'm asking this question because we have a general group also. Theoretically, when you recess the two muscles in the same eye, medial and a lateral rectus, you kind of you're undoing the effect of what you actually wanted. How do you counteract that by changing the dosage?
Dosage is going to be difficult. We have to titrate and form your own table. And unless you have a series of your patients start analyzing, it's difficult to make a generalized statement. Having said that, if there is a patient with exotropia, I'll do a little more lateral rectusization than is normally needed and probably add the other eye. But the dose, it has to be on an individual patient-to-patient basis.
Yeah, so we would do more of a lateral rectus recession than what we actually planned because we are doing a medial rectus recession also. Yeah.
Correct. If the patient is having exotropia. Correct.
Okay, right. Yeah, I think we have nicely covered exotropic DRS today. All the possible surgeries, what instruments to keep in mind, what precautions to take. We have covered all these today. It's been a very fruitful discussion. And anyone else has any comments or questions to ask us from the audience? or any amongst the moderators or Dr. Rishi, anything
Not
to
a
add?
question, just a general statement because it's more of general ophthalmologist. Other thing that can happen with these patients is abnormal synkinesis. So the typical thing is they can nearly 5% of them might have apparent tearing while eating, so it's crocodile tears, and some might have markers than jaw winking. So these are things that you might inquire during the history. And in the past, thalidomide was associated with Duane's-like picture. So of course, we are not using it now, but always we need to ask a significant history regarding use of any medications or substances during their pregnancy. So these are the things which we normally miss. And other things we miss is checking for virgins. We check for version, we check for duction, and sometimes we forget to check for divergences. So always check for convergence, whether the near point of convergence is fine. Is there remote? It becomes very important in planning your surgeries, especially in the esotropic plans.
And for the PGs, postgraduates who have joined here, we initially we were discussing about how certain DRS some types affects only the left eye. So for the PGs, there is this very nice paper by this person by name Cameron Parsa. You can read his paper. He explains why a lot of these congenital cranial degeneration syndromes happen in the left eye. It's a little that it's a nice paper to read. It's a very you'll find some very surprising facts. So please do read it.
If you have time, I can brief them a little, and if
Yeah, sure.
anybody
Yeah,
has to
yeah.
add, you can.
Yes, yes.
So basically, females there is a more risk compared to males, and the reason is supposed to be the X-linked chromosome, because which is some of the chromosomes might exhibit freely in females. That is one reason, and second, as is the female, I mean, in utero, female kids are more prone for inflammation and more prone for prothrombotic events. So these are the reasons why females are more common than males. And the second reason why if left side is common is because of these prothrombotic tendencies, there's a physiological right to left shunt in the heart. So because of this, all if at all there is any thromboembolic phenomenon, it traverses into the left side of the heart and into the left carotid artery, which is supposed to get lodged in the nucleus of the sixth nerve or the other nerves in the brainstem. And this is supposed to be the reason for left eye predilection.
Yeah. Yeah. So, but still, the PGs, that does not an excuse for you guys not to go and read the paper. Okay. So, sir made it easy for you, but you should go read it. Yeah. So, thank you. I would like to first thank Dr. Rishi and the our moderators for such a nice, engaging session today. I would now like to invite Dr. Mona Kurana. She's the Deputy Director of Glaucoma Services at Shankar Nethralaya. She would give her take on the session today in the form of some points, takeaway points.
Thank you, Dr. Akshay, for the kind introduction, and it was a very interesting session today. So, we discussed the dilemma of decisions in Duane syndrome. I would just like to summarize as I normally do in the Powwow sessions. So, when we operate, first is what is the indication for surgery, which was discussed. It's most commonly an abnormal head posture, which is significant, abnormal eye movements, which are not good cosmetically, and pre-wedding also is also an indication, and
Most important.
multiple indications must exist, of course. Abnormal eye movements or limitation of movements are less noticed by the parents or the patient themselves, and it's important, as it was discussed, to have good chair time with these patients to explain everything regarding the surgery and the post-op things which need to be taken care of. So the most popular procedure is weakening the lateral rectus, which is by recession and wide split. Like Dr. Akila said, it can be fibrotic and can snap, so you need to be careful. Um, so she also said that if in upshoots and downshoots, you should always differentiate mechanical from neurological, because it may not work well in neurological, where you may need to tackle the vertical muscles. And Dr. Rishi very beautifully explained the physics of the Y split, and he combined two difficult subjects like physics and squint to make it simple, and basically how it affects the torque and how this whole surgery acts. You will need to be prepared with special instruments when you do this. A marker, a Desmail's retractor for a large exposure of the conjunctiva. With a heavy heart, I say that being a glaucoma surgeon. So, and of course, you need an iris repositor or a Sinsky hook to get the split. First, you make a buttonhole and then you do a split, or a Gruel hook, like Dr. Akshay suggested. And sometimes you may don't not want to lose a muscle, so you may want to put a tight temporary suture there, like what we call a stay suture, to prevent losing the muscle. When there are large bilateral Duane syndrome with small upshoot and downshoot, you can just do a bilateral LR recession, may not split it. And there are basically no surgical nomograms. You have to find your own nomogram. And in case of unilateral large DS with the, you may do bilateral LR, or with more on the normalized side. So other surgeries which you can do depending on the indication are the modified Nishita, the MR recession, but then you need to be careful because they can go the other way around also. Sometimes a staged procedure is also preferred. And do not forget to manage the amblyopia and look for systemic associations. And happy managing these cases, and it's very challenging cases which you all manage, and hats off to you. Thank you so much.
Thank you, ma'am. You summarized it so well. I think you covered everything in just 2 minutes. What we spoke for 45 minutes, you covered in 2 minutes in detail. And I could see the pain when you mentioned about the conjunctiva. So, yeah. So, thank you
Very
so
well.
much. So I would like to thank first. I would like to thank Dr. Shikha, I think, for putting together this program where all of us come together in a very informal and friendly setting to discuss these cases. Thanks, Dr. Rishi. You took out time from a busy evening. I'm sure you've just finished your OPD, and you took out time to come and present these cases. To Varda, Dr. Ramprakash, and Dr. Akila, thank you so much. After
Thank
a
you.
tiring day on a Friday evening, to come and give pearls to from which all of us have learned so much. Really, thanks a lot. And to all the people who have come today to listen and watch this program, thank you. Thanks to the multimedia team for always being there to help us with any troubleshooting. Thanks a lot.
Thank you, Akshay, and thank you.
Thanks, Dr. Akshay, for a great show.
Thank you so much. Thank you.
Thank you.
Thank you. Bye. Good night.
Bye.
Good night. Enjoy your weekend. Bye.